بسم الله الرحمن الرحيم. This is a diseases of the aorta. The aorta itself is the artery which receives blood from the left ventricle and supplies the whole organs. The maximum diameter of aorta is 3 centimeters, and histologically there are 3 layers: intima, media, and adventitia. With aging process, the elastic tissues fragment and decrease, while collagen fibers increase on the expense of smooth muscles, which decrease in amount. Also, mucoid ground substances increase in amount, causing cystic medial necrosis, where there is a loss of lamellar structure and formation of lakes of amorphous material. This cystic medial necrosis increased in bicuspid, aortic valve, Marfan Syndrome, and Lewis-Dietz syndromes. All these changes rendering the aorta less distensible, stiff, dilates, elongates, and the arc becomes unfolded. As we said, the maximum diameter of the aorta doesn't exceed 3 centimeters. So if there is increase in the aortic size more than 1.5 to 2 times more than normal, this is considered as aortic aneurysm. Or if it exceeds or equal to 4 centimeters in the thoracic aorta and 3 centimeters in the abdominal aorta. The types of aortic aneurysm. We classify the types according to the morphology, the shape, and the anatomy, and the etiology. According to the morphology, if the aneurysm is lined by the 3 layers of the aorta, so this is true aneurysm. If there is perforation and the aneurysm is lined by the surrounding structure and fibrous peel, so we call it false aneurysm. According to the etiology, may be connective tissue disease such as Marfan, Lewis-Dietz, Danlos, or other causes, or atherosclerotic and infection. These are the most common causes. According to the location, may be thoracic, may be abdominal. The thoracic is confined to ascending aorta, arch, or descending aorta. The abdominal, in most of the cases, aneurysms in the abdominal aorta usually lie below the renal arteries. The third type may be thoraco-abdominal. From the thoracic portion extend into the abdominal portion. According to the shape, it may be fusiform, as we can see in the next slide, where the dilatation affects the whole circumference, or may be saccular. Saccular means part of the circumference is dilated. As we can see here in this 3D CT picture for the aorta, we can find 3 aortic aneurysms affecting ascending aorta, arc, and the descending aorta. We can also notice fusiform shape and saccular shape aortic aneurysm. On the right side, this picture is taken from intraoperative procedures for abdominal aortic aneurysm. According to the location, the types of aortic aneurysm may be confined to the thoracic, as we said, or the abdominal or thoracoabdominal. Regarding the thoracic portion, it may affect the ascending aorta, and usually it is Connective tissue disorder, mostly genetic determined, Marfan such as Marfan, Lewis-Dietz, Ehlers-Danlos, bicuspid aortic valve, and usually it may be supracoronary aneurysm. It lies above the coronary artery. It may extend from the annulus to the aorta. We call it annulo-aortic ectasia, or tubular. Tubular similar to annulo-aortic, but the shape is cylindrical. That's all. So we call it tubular aortic aneurysm. Regarding the descending thoracic aortic aneurysm, they are usually atherosclerotic. Abdominal aortic aneurysm usually located below the renal arteries in more than 90% of the cases, and they are usually atherosclerotic in nature. The same for thoracoabdominal aortic aneurysm are usually atherosclerotic in nature. In this slide, we can see different types of aortic aneurysm taken from different investigation procedures. On the left side, at the upper left, we can find a picture taken from angiogram for the aorta with annulo-aortic ectasia. The left lower, another angiogram for aorta showing abdominal aortic aneurysm just before the carina or bifurcation. In the middle, we can see 3D picture for aorta taken from CT. It shows descending thoracic aortic aneurysm. It lies below the left subclavian artery. On the right side, the upper right is simple chest X-ray showing dilatation of the aorta. On the lower portion, there is saccular aortic aneurysm taken from angiogram for the aorta. Of note, this saccular aortic aneurysm affecting the descending thoracic portion is very liable for perforation. The epidemiology of aortic aneurysm. The incidence of aortic aneurysm is 5% in patients above 65 years old, more common in men than women. And the incidence of aortic rupture in general is 10 patients per 100,000, while the incidence of rupture of aortic aneurysm is about nearly 7%. Regarding the etiology of aortic aneurysm, as we said before, the inherited diseases come firstly and usually affect the ascending aorta. It includes Marfan Syndrome, Ehlers-Danlos syndrome, Lewis-Dietz syndrome, bicuspid aortic valve, and familial thoracic aortic aneurysm. The second most common causes is atherosclerotic. And usually it involves any segment, but usually in the thoracic portion, the descending thoracic portion, and the abdominal aorta. Other causes such as aortitis and idiopathic may be encountered. In this slide, we can see some of the inherited clinical disorders or genetic disorders affecting the aorta causing aortic aneurysm. The first one is Marfan syndrome. The cause is usually disorders affecting tissue growth factor beta signals leading to destruction of elastin fibers. Of note, TGF-beta is responsible for growth and development of body tissues. Clinically, as seen in the slide, the span of the arms is longer than the body height, which is usually equal. The fingers and the toes are thin and tall. The thumb is outside the edge of the medial side of the hand, which you call thumb palm sign. Also, the patient can encircle the wrist of the hand by the thumb and little fingers, which is normally cannot be done. There is high arched palate, subluxated eye lens, tremulous iris, dilatation of the aorta, aneurysms of the ascending aorta, and if it affects the annulus of the aortic valve, it will cause aortic regurgitation, and also mitral valve prolapse may be present. On the right side, we can see some clinical picture of the Ehlers-Danlos syndrome. It was discovered in late 19th century by two scientists, Ehlers from Denmark and Danlos from France. The cause is, as before, disorders of TGF beta and characterized by excessive laxity of tissues as skin, musculoskeletal system, and blood vessels, producing lax skin, atrophic, translucent, hyperelastic, and easily bruising skin. The joints and ligaments are also lax, leading to hyperextension of joints, deformities of fingers, spine, dilatation of blood vessels, and aneurysmal formation of aorta and varicosities. The third most common inherited genetic disorders affecting the ascending aorta is Lewis-Dietz syndrome. This disorder was discovered by two pediatric geneticists in 2005 at Johns Hopkins University in USA، ودي اللي بتطلع لنا الإحصائيات بتاع الكوفيد 19 اللي هي حاليا في أمريكا. Same cause due to disorders affecting TGF beta disorders, leading to decreased senses of collagen, especially at skin, clinically, the skeletal spinal deformities, bifidobula, very important, bifidobula, pivot palate, and this to differentiate from other types, low-seated ear, skull deformities, fingers and tooth deformities, club foot, contracture of fingers, premature fusions, excuse me, premature fusion of bones producing craniostenosis, pectus excavatum or carinatum, spinal kyphosis, scoliosis, translucent skin, bicuspid aortic valve, aortic dilatation, and aneurysm, congenital heart disease, including ASD. The fourth type is a bicuspid aortic valve. Simply, the aortic valve has three cusps, but usually in some cases during intrauterine fetal life, two cusps fuse together, forming only two cusps, and thus the opening of the aortic valve during ventricular systole transform from circular, which is large, into elliptical, which is smaller, produce and consequently aortic stenosis is produced. So the jet of blood is high, and this will increase the force of dilatation, affecting mainly the ascending aorta. The incidence of bicuspid aortic valve is nearly 1 to 2%, and as we said, it is caused by fusion of the two cusps, which may be not perfect, causing also aortic regurgitation due to defective fusion. And this speed will increase the velocity of the aortic jet, will increase what we call medial cystic necrosis, causing more dilatation of the aorta and consequently aortic aneurysms. What about the pathophysiology of aortic aneurysm? As we said before, most of the cases in the ascending aorta is genetic basis. A lot of genes are linked to aortic aneurysms. Some materials such as matrix metalloproteinases and tissue inhibitor of metalloproteinases causing destruction of tissue matrix and thus weakening of the aortic wall, and this will add more to the dilatation of the aorta. In addition to chronic inflammation, smooth muscle cell apoptosis, and matrix injury, degeneration, and aneurysmal formation. And this is the rule for TGF beta. It causes more apoptosis and more degeneration of the wall of the aorta. The consequences from outside, the aneurysm will cause pressure on the nearby structure. At the wall, it will cause dissection, rupture, and side branch occlusion, or even aortic valve malformation, especially at the annulus, causing aortic regurgitation. The effect on the lumen, usually due to dilatation, thrombus formation, and thromboembolism, and even infection. Regarding the death rate, within 5 years, it is very high. It reaches 50%. What about the clinical picture? In most of the cases, aortic aneurysm is silent, especially in the thoracic portion. Abdominal masses, if it is so large, and we have one slide with a picture for a patient with abdominal aortic aneurysm done in King Saudi Arabia. The thoracic one is usually silent, as we said. The pressure effect on the nearby structures, such as coronary arteries causing ischemia and even infarction, trachea, hoarseness of voice if it affects the laryngeal nerve, duodenum, inferior vena cava. It may rupture also in the nearby structures such as right ventricle, pulmonary artery, right atrium, trachea, lungs, duodenum, peritoneal cavity, pleural spaces. There may be acute dissection which causes severe pain. We will discuss later on. This pain is usually severe, tearing in character in the chest and maybe in the interscapular region, in the flanks if it involves the abdominal portion, and in the lower limb. Also, it causes compression on the coronaries, cerebral, subclavian, spinal, mesenteric, lower artery, so the patient may present with any form of ischemia, any form of infarction. Regarding the affection of the aortic annulus, it causes aortic regurgitation, so the patient may present with manifestation of severe aortic regurgitation or even mild, and later on heart failure. And this, it is called great masquerader. يعني بيخش في differential diagnosis in a lot of patients. Physical examination, we cannot find, sometimes we don't find any physical except for genetic inherited diseases. But for the aneurysm, some cases we cannot find any physical findings, physical signs, but in some cases we can see the pressure effect on the vessels, unequal vessels, pulsation in the upper limb or in the lower limb or between the upper and lower limb, ischemia, coronary, cerebral, thromboembolism, aortic regurgitation is very important. we can hear early diastolic murmur at the aortic area. So a lot of findings, we can find a lot of findings depending on the site and the effect of the aortic aneurysms. The investigations of cases for aortic aneurysms may be as we can do for every cardiac patient, ECG, chest X-ray, and echo. Here also echo may be very, very important if it affects the ascending portion. And in some cases we can detect by echo aortic aneurysm involving the arc. TEE or transesophageal echo is very, very helpful in the diagnosis of aortic aneurysm and its complications such as thrombus and aortic dissection. So echo is very, very simple and very visible. Chest X-ray or X-ray at any level, mainly the chest X-ray, we can find some dilatation at the hilum, suspecting aortic aneurysm. But the definite diagnosis, in addition to echo, is the CT and the MRI. They definitely can diagnose cases with aortic aneurysm, and also we can measure the diameter of the aorta, which is very important in the management of aortic aneurysm. Also, they can detect complications such as thrombus and dissection. Other biomarkers, we can do biomarkers in most of the cases. We can find elevated D-dimer if there is in aortic aneurysm. Differential diagnosis, and we can say the differential diagnosis, it is a great masquerader in cardiology because it affects the chest, affects GIT, affects the lower limb, head and the neck, brain. A lot of differential diagnosis may be caused by aortic aneurysm. The natural history of aortic aneurysm, it usually increases in a rate of 0.1 to 0.2 centimeter per year، يعني 1 ل 2 ملي per year unless there is aortic dissection. So the follow-up by CMR or CT is usually every 2 to 3 years. And rarely the rupture is very rare if the size is less than 4 centimeters. That's why we have to do follow-up visits for patients with aortic aneurysms. Let's see some investigative tools, such as the simplest one is the chest X-ray. We can detect mass or enlargement at the base of the heart. It is actually for differential diagnosis, but in this case we can see on the left side dilatation at the hilum of the lung because of dilated aorta, or we can say aortic aneurysm. On the right, the normal heart or the normal chest X-ray, for comparison, it is devoid from the enlargement of the base. In the middle, this angiogram was seen before for dilated aorta in what is known as annulo-aortic ectasia. This slide also shows some pictures taken for patients with aortic aneurysm. On the lowermost and right, we can see pictures for aortic aneurysm involving the ascending aorta. This covered by transesophageal echo, in the middle 3D CT, on the left side the MRI and CT very low. Regarding the indication for intervention, aortic aneurysm should be treated by medical treatment as long as there is no symptoms or there is no complication. But the indications for intervention, mainly by surgery, is number one, symptomatic patients or complicated patients, regardless the size of the aneurysm. Rapid increase in the size approaching 1 centimeter per year, this is a good indication for intervention. We will not wait until rupture occurs. Okay. The absolute size for intervention is in the ascending aorta 5 centimeter, in the descending aorta 6 centimeter. So in Marfan patient 5 and 6. In non-Marfan 5.5 and 6.5. So يعني بالبلدي كده إذا كان عيان مارفان يبقى 5 و6، قاعدة 5 و6، نون مارفان 5 ونص 6 ونص، ودي المتبعة في جامعة يال في أمريكا. مفيش there is no consensus all over the world، ولكن it depends on the size of the aorta. As we said before, the size of the aorta usually rupture if it is bigger than 4 centimeters. So this is from a qualified center depicted from Yale University in USA. Regarding the medical treatment, as we said in asymptomatic patients or during follow-up, the most important medication is the ARP, especially losartan. Why losartan? Because it affects TGF beta. So it reduces apoptosis and the dilatation force occurring after dysregulation happening to the TGF beta. It reduces also blood pressure. So it reduces the dilatation force affecting the aortic wall. Beta blocker, actually, its effectiveness in reducing aneurysmal dilatation is equivocal. Meta-analysis published in New England Journal of Medicine 5 years ago proved that there is no clinical benefits in patients with Marfan syndrome. Moreover, reduction of dilatation is not evident in all the trials over patients with Marfan syndrome. However, there is beneficial effects in cases of acute aortic dissection type A, while type B benefits from calcium antagonists. Regarding surgical treatment, they usually excise the aneurysmal portion and put a conduit, usually from dacron. Usually in the ascending aorta, our famous doctor Magdy Alghowhary is a pioneer surgeon in the treatment of ascending aortic aneurysm with preserving aortic valve. The aneurysm is resected and the dacron tube is used to replace the aneurysm. Dacron tube is very convenient as it doesn't require long-term anticoagulation. Of note, coronaries must be patent after surgery. If the arch is affected by the aneurysm, they resect the innominate artery, coronary, left carotid, and left subclavian as one patch and excise the aneurysm, put dacron, and insert the patch in the dacron tube, which is connected also to which will be connected to the distal aorta. So we have to keep the carotid subclavian arteries patent after doing the surgery. If the aneurysm affects the distal descending aorta, the surgeon should keep vital branches patent and remove the aneurysm and replace it by dacron tube. Important branches in the thoracic or in the abdominal portion is the celiac trunk, mesenteric arteries, renal and spinal arteries. Very, very important to keep them patent. Of note, if the coronary arteries are diseased by atherosclerosis, according to there is no consensus actually, but it is better to do or to perform cardiac TEAM. Some cases we can do coronary intervention, but what we call PCI, and leave the aortic aneurysm for surgery. Some cases the surgeon do the coronary artery bypass graft, what we call cabbage, and the aneurysm. In some patients, hybrid is okay. So according, it is case by case in patients with coronary artery disease. The last thing is the endovascular treatment by graft stent. Regarding graft stent, it is usually left for inoperable patients or patients with acute imminent complications such as rupture, aortic aneurysm, or aortic ulcer. The endovascular treatment by stent graft, as we said, it is best used as a bailout procedure in cases undergoing perforation and surgery cannot be performed. Why? Because we have a lot of trials such as EVAR, DREAM, and STEAD trials don't show superiority of endovascular treatment over surgery. However, Erotic trial shows some benefits over surgery in type P dissection. So we have to select the patient for stent graft. The most of the drawbacks of stent graft comes after putting the graft is the leakage and passing of blood into the aneurysm. There are 4 types of passing of the blood into the aneurysmal sac after the graft. We call it endoleak, usually due to leakage at the proximal junction with the aorta, or at the distal junction, or deformed materials of the stent graft, or the graft itself may ooze. The stent graft itself may ooze, filling the aneurysmal sac. So this is a problem of the stent graft. Anyway, it works very well in emergent cases. This picture is taken from for a patient done in King Saudi Arabia in 2009 with huge abdominal aortic aneurysms, and is published as a case report in one of the most famous medical journal, New England Journal of Medicine. Another important topic is aortic dissection. It may occur on top of aorta with aortic aneurysm or without aortic aneurysm. It is defined as a splitting of the medial layer of the aortic wall, permitting longitudinal propagation of blood between the components of the aortic wall. So, The passage of blood into the false lumen will cause tear in the intima or the intima media space and compress the true lumen, not only at the affected vessel but also the side branches arising from the affected portion. In this slide, we can see aortic dissection diagnosed by CT. At the right upper slide, there is true and false lumen with thrombus. At the left lower picture, we can see descending aortic dissection with hematoma outside the true lumen. It can be seen easily by CT angiography with contrast. One important points or two important points. The first, the treatment. The treatment sometimes resection and then anastomosis. We must seal the tear. This is by surgery. The second important point is the cause of serious problem for the patient with aortic dissection. Firstly, if it causes severe aortic regurgitation, if the dissection extends beyond proximally and involves the annulus of the aorta, so the aortic cusps will not close properly and severe aortic regurgitation might occur. The patient will have acute heart failure. And if the dissection open into the pericardium, the patient will have cardiac tamponade. He might die unless emergent treatment is performed. Another serious problem if it occludes the coronary artery. It will cause acute myocardial infarction. If it occludes cerebral vessels, it will cause cerebrovascular stroke. If it occludes spinal arteries, it will cause paraplegia. If it affects mesenteric artery or renal artery, it will induce acute renal failure or intestinal obstruction. If perforation happen, the patient will be shocked. So we have to be careful, and immediate diagnosis is mandatory for such patients. This will be the last slide with my best wishes for all of you, and we are ready for any questions and happy to help you. Thank you very much. Good luck.